I was not very confident that I was going to make it to medical school. So I was actually resigned to the fact that if I score an A-, I'd even made my choices. I'm just going to go into engineering and do it because that is what I have qualified for. But really, that wasn't really in my heart. And, I told him, well, I think I've prepared. I'm going to get a straight A. Patients never really sometimes get to know what you've gone through. A patient with a very simple tumor and one with a very complex tumor having the same results, both of them will never know what was worse or what was most challenging. I think we actually do all of the most complex cases locally.
But I would still imagine there might be cases that still make you a bit nervous.
So certainly they will always have that. But over time, I've learned to actually audit myself.
So, Doc, very interesting story. You said you grew up in Kericho town and you went to Kericho Primary School. And then from there, you went to Lenana School. Tell me, at what point did you start thinking about being a doctor? Or was there a defining moment that really made you think, maybe I should be a doctor?
I don't know whether to say this, but I normally feel like my situation was a little unique. We usually talk to children and they have childhood dreams about what they want to be. Mm-hmm. And that later changes, as soon as, they have an idea about, what they're really thinking about, what they really want in life.
Yeah.
Interestingly, for myself, I remember, used to make fun with a little cousin of mine. We probably were around 6-7 years of age. Mm-hmm. And, I told him, and, we used to tell our parents, well, I want to be a neurosurgeon. My cousin wanted to be a cardiothoracic surgeon.
Okay.
And interestingly, this dream and childhood dream stayed with me all through. Mm-hmm. So, I can only say that, it's something that started as a child and I never changed. On the contrary, my cousin, just like many others who have childhood dreams, mm-hmm. I don't know when it fell off, but he never went anywhere near medical school, went into commerce mm-hmm. and became an accountant. Mm-hmm. So it's something interesting because, I decided mm-hmm. I want to be a doctor and I want to be a neurosurgeon mm-hmm. at a very young age. Mm-hmm. And, and I kept, that dream alive all through. Mm-hmm. And, graciously, thanks to God, some of things ended up working out. Yeah. In spite of all the, challenges and what you can call, mm-hmm. Bridges that we had to cross to get there.
Yeah. So, Lenana School is not one of those, it's a national school, but back in the day, it was not one of those schools that really performed that well and was known for quite a bit of vices and a bit of problems, strikes and stuff. How was it for you going through Lenana School and what was your experience there?
Interestingly, when we talk about strikes, I think that's probably what we enjoyed. The bigger vices in the institution that I feel are less talked about include such issues such as bullying. So I remember, going there in my first term, mm-hmm. and over half term, I came back home and I told my father, I'm not going back to that school. Mm-hmm. You find, and interestingly, well, he just kept quiet. He never answered anything. Mm-hmm. Come opening day, I was still packed up and went back to the same school, mm-hmm. survived the bullying. Mm-hmm. And many other issues, but going through the same school as you've stated, it wasn't really it was better known for all these vices, better known for other good things such as rugby. Mm-hmm. That's another thing that we enjoyed there. But in terms of academia, as I had earlier stated, wasn't really one of the top schools, but we still appreciate how much it could mold one. Okay. Mm-hmm. It sort of was an institution where the self-drive was what was most important. So you had students being graded. Maybe during those times we'd have maybe one mm-hmm. or two students score an A plane, mm-hmm. and in the same setting you'd have at least one score an E. That's quite a unique landscape in terms of academic performance. Mm-hmm. Really, why I note that actually self-drive was very important is because I remember, by the time I was in my Form 3 or Form 4, I would probably say I was in the top 10 students. But, top 10 clearly doesn't guarantee you a place in medical school in such a place. So in Form 4, I thought to myself, well, if I really want to be this doctor that I want to be, I have to sit down and do something. So, I took that opportunity all the way in the Form 4, second term especially, and, really prepared myself for the exams. I know, had the potential, but, that potential has to be brought out by self-drive. So really worked hard through that term, and by the time we got to the examination, the KCSE, I remember sitting to one of my classmates, and, he made a statement to me and told me, well, judging from my past performance, he told me, well, you're very happy. You must be happy that you're guaranteed you're going to get at least an A-. And I told him, well, I think I've prepared. I'm going to get a straight A. And he actually laughed, and we were in the exam room. He laughed and told me, you forget about that. That's not within reach, because it was always one student, two students who would, and there were people already poised to actually score that. So I've never gotten to meet him in all the years that we've because I ended up scoring the A. I told him that I had marked out. So that's one thing that taught me about this school. So and that's one thing that also tells me a lot about whether it really matters which school you go to. And that's why I stated that I don't know whether it made a difference which schools we went to in primary. Because when I went to medical school, I met people from schools that are unheard of. I'll give you the names and you've never heard of them. But the self-drive in those schools and the discipline actually got them through.
So do you feel like Lenana School set you up for your current practice? Because medicine really is about self-drive, and especially coming from Moi University where we work, we are a self-directed institution. Do you think that played a role?
Yeah. I wouldn't state that some of these voices that you're talking about were, but I feel, the environment and the school itself actually set me up for, especially the Moi University Medical School, which had a different system of training, also something called self-direct learning. So you never really get any lectures. You get overviews and direction. That was, that was then. And it's your work that will actually push you through self-direct learning. So I think we'd had some preparation from Lenana School, and I felt it also hardened me for life. Not everything is straightforward. Neurosurgery is, has its own lots of challenges, but I feel the not to say that the bullying was good or in any way, but I feel it actually hardened us.
Set you up for.
And set you up for, difficulties that you're going to go through.
So apart from academics, because Lenana School is an all-rounded school, I think the right thing to say about Lenana School is it's a school that is all-rounded. There's a lot of rugby, there's a lot of arts and drama, and then there's academics. Did you do other things apart from straight academics back in school?
I believe this is one of my regrets. Every time I talk to my children, I tell them, well, don't be like me. I feel I didn't do so much outside the academic realm. But, well, at some point I actually did play hockey, so some sports, did participate in a number of other extracurricular activities. Some of them are still related to academic work, such as things like the science congresses and so forth. But looking back, we also had a negative attitude towards some of these extracurricular activities because, for example, it was guaranteed if you went and joined the rugby team, you would not perform well. And this is unlike in the past. We used to, get stories about, the past events in the 70s and 80s where the rugby players are the ones who actually performed well. But during my time, it was sort of guaranteed if you're a rugby player or, heavily immersed in sport and other extracurricular activities that you wouldn't. So it was just, just a notion. But looking back, of course, I think I should have involved myself more in, other more extracurricular activities. Okay. Yeah.
So obviously, I believe you must have scored an A then, contrary to what your friend thought. and you went on to go to medical school. Tell us about that experience, the results coming out and you being invited to medical school. And was Moi University your preferred choice for medical school?
Yeah, so during that time, of course, we had our selections of our preferred courses and universities at the university. Not at the university, but at the high school level. Yeah. So interestingly, there were only two medical schools then, to University of Nairobi and Moi University. I don't know whether it's right to say this, that I felt, well, if I were to qualify to a medical school, probably it would be easier to qualify for Moi. Maybe I was a little timid about my chances actually succeeding. So I actually selected Moi University as my first choice. And then the results came out, and I was qualified to go to any medical school of my choice. So at some point, I actually wanted to change and go back to the University of Nairobi. But you know, my parent, again, I had to listen to him, came and told me, well, there seems to be a lot of privilege here of going to the Moi University. You will have a chance to travel on electives to, you know, a number of other countries in Europe or the US. You know, all this sounded good. So yeah, I stayed put and actually went to Moi University. Okay.
So tell us about your medical school journey. And how did you find this new system of learning at Moi University?
I definitely, like everybody else, you know, you had your new challenges. Immediately you arrived, you know, it was a shocker, maybe so to say, that you have very minimal lectures. And I think, if I remember well, I think my initial stressful moments, probably what chased my colleagues out was, the morgue and doing the dissections, but that wasn't even the main thing. You know, I remember I was used to, you know, studying and having logic about everything. Now came this new way of learning where you had to memorize everything. And I think for the first few weeks, I think I had challenges, you know, memorizing all this, you know, especially in anatomy. So I would come back from the anatomy lab and find that I couldn't remember a single muscle on the lower limb. And I thought, well, this is going to be difficult. But we caught on anyway, and managed, of course, to transition to this phase, managed to learn the system and go through it. The first three years weren't that bad. Of course, the exams there and so forth. I think my most stressful moment in medical school was actually my fourth year, which was the first year. We did a 6-year program then. So my first year in the clinical years. And then I saw, you know, the people in the previous class, you know, see somebody study for a whole 4 years and get discontinued because they failed probably 2 of the 4 major subjects, and you actually get discontinued. That was actually quite a stressful moment going into the exam at that point, knowing that you know, any failure, and you know, this is subjective teaching, you know. A clinical examination is essentially subjective. You can get a student who is probably very good but actually get thought block and so forth, forgets you know, basic things that the teacher thinks is too basic and fails them when they are not really a poor student. But I think over time all this has been refined so that examination methods actually truly reflect actually the students' content and so forth. They're much more objective. So at that point we thought, well, it didn't look, but we had no chance, of course, of airing our concerns. You just had to pass the exam. So I think, but eventually, of course, we made it without much scar and eventually graduated. So yes, medical school was challenging at that point. So, you know, yes, we had that stress. I remember 3 of my colleagues were actually discontinued in 4th year. And probably had to find an alternative medical schools because you're already too far into the field. So they actually went to other medical schools in other countries and eventually made it.
So it sounds like did you enjoy medical school that much or not that much?
Well, you know, as things got easier in medical school, then you actually learned to enjoy it a lot. And as you learned the ropes of the trade in the medical school. So so I think my medical school was quite fair, in my opinion.
Now, and then from medical school, obviously, then you went on to do your internship. Where did you go for your internship, and what was the experience like?
So I went to internship to Kericho. This was influenced by a number of things. There was political issues at that point in time. So I went to Kericho, the county hospital, and I think I really enjoyed my time there. There was, quite a number of helpful consultants, and allowed us really to train a lot, and I think I appreciated those moments at the internship station. There were, in spite of the few challenges there, got some extra weeks in the my favorite department, which was surgery. But at the end of it, I actually appreciated it, that these weeks actually saved me from being posted to Lodwar, for example. So I ended up being posted in the same center. I think, eventually they made their whole evaluation and realized, well, they still needed to retain me. But I worked there for a short while because I really needed to focus on the future and see how I was going to get into the training program, the neurosurgery training program, which was a big challenge at that point. That's briefly about my internship here.
So you didn't stay in Kericho for long. You obviously must have then moved to MTRH. Is that so?
Yeah, I had to move to MTRH. Maybe to summarize the story. At that point in time, there was a director of medical services in Kenya. And I must remind him, in case he's still watching and still around, he was called Dr. Kimani. Dr. Kimani, this is year 2006, 2007. And I feel Dr. Kimani was actually, his ideas were, should have been left long in the past. But his ideology about, the practice and healthcare in Kenya was about, treating the masses only. So he considered what was useful for the masses to be more important than the smaller parts of the populations who required a service. In other words, treat the majority of the people. Let's say if there are 100 people who are sick in a hospital and 80 have malaria, that's the most important thing. If if another 10 have surgical wounds, basic surgical wounds, also consider that. But if only one of 100 people have a brain tumor, that's not as important. That's how he thought about it. So neurosurgery was never considered to be an important field as much to him as other fields. So he never considered that he needed to sponsor anybody to do these small subspecialties. And therefore there was no sponsorship from government. Kericho was a government facility, and I was not going to. So I went for my first interview for neurosurgery. Even before talking about that in the background, through medical school, I used to think about how am I going to get into neurosurgery. There was no program in Kenya. So, I was already resigned to considering the old path that my predecessors, my seniors took. So, do general surgery and find a path to go maybe to another country and study neurosurgery. But come around the year 2006, and when going through the newspapers, I saw the advertisement, finally. So the University of Nairobi had created a curriculum for a Master of Medicine in Neurosurgery. So I knew this is where I wanted to go. So come finishing my time as an intern, I applied for the first time. Immediately I finished my internship, applied for the MEd and went for the interview. And how the interview went was, I think the first question, if I remember well, from who is your father? And I kept wondering how important this is. Only to look back and discover that actually most of the people who went through that program needed to be able to afford the program, to be afford to be self-sponsored, pay for all your needs and pay the school fees without struggling, because the government was not sponsoring anybody for that MEd. So when I told them my father was a farmer, they told me, okay, fine, let's help you. You try and go and find a place that can actually sponsor you for this course, because the government doesn't sponsor it. We don't think you can afford to be I thought that sounded unfortunate, because that seemed to look like farmers are really poor. Well, mine wasn't rich, but that was the fact.
Yeah.
So that is how I ended up deciding to actually transfer to MTRH. Again, that was a different challenge. I had to either transfer to MTRH or to a teaching institution that at Moi University. I tried as much, as possible, always traveling, finding excuses to travel and try and meet the vice chancellor. I eventually met him. That didn't succeed. Had to wait for a slot in MTRH. There were no slots. Eventually, there were slots because they released so many people to go for their MEd, and I think you were one of them who created a slot, and I was lucky to get a slot to transfer into MTRH. So at MTRH, at least they had the need, because at that point they had only one neurosurgeon who had just come back, I think, the previous year, Dr. Koech. So they had only one neurosurgeon, and there was need to actually train more. But still I had to work in MTRH for about 2 years before being allowed to go for my MEd. So that was the journey.
Wow, that's an interesting story, because people won't really appreciate that. People think that it's very easy to go to school, but I can see that was really a big challenge. And so you went to the University of Nairobi and did your neurosurgical training. How long was the training, and how did you find it? Was it a challenge?
Yeah, I think my challenges started immediately. I went to the University of Nairobi. Now, this is a very interesting story. I think I've told it to a few colleagues a few times. So I finally complete 2 years. My other colleagues maybe would take a year in MTRH and get a sponsor. So finally I've done 2 years with a lot of struggle to convince the administration to allow me for the MEd, and finally they've granted me that sponsorship. That time we earned very little, so I had to sell most of my baggage to be able to fit into the lifestyle in Nairobi. Even sold my car. And then I arrived in Nairobi. I think I've settled in some small room in Kenyatta Market, and I'm in matatu traveling back, I think, to my village to tell my parents, now I'm ready. I've now left Eldoret. And somewhere in the middle of the journey, somebody calls me and tells me he's calling from the Board of Postgraduate Studies, and he tells me that we are calling you to ask you to come and defer your studies because you were admitted unprocedurally, that there was a mistake and you actually got an admission letter. That really shocked me, and I had to stop my journey somewhere in Nakuru, get back and to the Board of Postgraduate Studies, only to find out there that there had been lots of argument and misunderstanding amongst the faculty at the University of Nairobi, and there are some who had actually suggested a certain list of trainees to be admitted, and some other faction was not happy and actually put in a whole different list and so forth, and we all ended up getting admission letters, a whole seven of us, including international students. That was a record number at that point, a point where we used to have 2 or 3 admissions for the MEd. Of course, we had to take this, because I was not the only one who received this message. There was a number of us out of the 7. So we took it upon ourselves to actually go and complain to the chair of the department, who was very helpful. I cannot forget Professor Ogendo, and who took the matter very seriously. You cannot have people get admitted, arrive, and you tell them on arrival that they have to defer. So I think the matter was eventually sorted out, and we proceeded with our training. The training generally was a 6-year program. Did not have so much challenge. I think the only challenge was the workload, but we got used to it. Operating for a whole week and doing the call for a full week at a time. But we got used to it, and eventually got to about our final years. And around my final year, somewhere again going through social media, I discovered, I was always looking for maybe a fellowship position and so forth out of the country. And I landed on this very interesting Commonwealth system scholarships, which had actually sponsored one of my very senior teachers back in the 90s. And we had never gotten such a scholarship again. So I decided to apply for it. Commonwealth, it's a medical fellowship that allows you to go and actually practice in the UK with minimum requirements, no examinations and so forth. You just have to prove that you are in a WHO accredited center and trade in WHO accredited centers and so forth. So, towards the end of my training, I was lucky to actually go for this fellowship in the UK. A pretty competitive scholarship, but I was actually lucky to get it. So by the time I finished my 6-year program, I'd already gone through my fellowship in the UK.
What do you mean? The training was 6 years, not 5 years?
No, it was a 6-year. That goes back again to the medical school. Sometimes I regret why I chose Moi University. Moi University was a 6-year program for undergraduate. University of Nairobi was a 5-year program. So I saw my colleagues come back for internship when I'm still in medical school. University of Nairobi was 5 years initially for the MEd, but that stopped within the first 2 years. And the curriculum was revised into a 6-year program. That is generally accepted worldwide as a standard. Yeah.
So you did 6 years of training, and by the end of it, you already had a pathway to the UK.
Yeah,
so tell us about that part of going to the UK. Where did you go, and how did you find the UK and the practice of neurosurgery in the UK?
Yeah, so the UK, I went to Liverpool. Incidentally, even my senior colleague went to the same place in Liverpool. So I found some of these very old colleagues, asking about it. That was, a difference of almost 20 years. So the UK generally, first of all, talking about the teachers themselves, I really appreciated their approach to teaching. I didn't feel segregated at all as being a foreigner and a newcomer. So straight away after all the requirements, medicals and so forth, I was allowed into theater. I was allowed to scrub in with the surgeon. And interestingly, I was treated as a senior resident. But let me say this for the record: there are a lot of things that I had not trained to do in my home country. And the first day I went there, and they thought this is a very simple procedure. So they asked me, proceed, you go do it. Yeah? And I had to go around and find some of the other residents to actually do the procedure with them. But that was generally the attitude there. So that they would allow me to do the procedures as comfortable as you are. Okay. So he will just sit back behind the microscope and watch you do what you're doing. And of course come in when he feels that it's necessary to give you the necessary support. So generally that's about it. The UK generally, most people find it was an easy place to train, and I think I learned quite a lot within a very short time. One is because I went to a center that is purely dedicated to neurosurgery and neurosurgical problems. I was used to having one theater in Kenyatta dedicated to neurosurgery. I went to a center that has 8 theaters running continuously the same day, 5 days a week. So you had the opportunity to learn so much and continuously. And then of course with technology, there's lots that we didn't have, and we still even don't have at this point in time. So I feel I gained so much to polish up the training that I'd had.
How long were you there for?
I was there just for 6 months. It was a
6 months. Okay.
6-month program.
Good. And then you finished there and you came back. And I presume that when you got back, you came back to MTRH, right? And how was it? How was that transition from training at Kenyatta and training in the UK and now coming back to MTRH?
So I must say, after such a training program, the initial time, I felt you always needed support of a senior colleague. So I remember I would always call on my senior colleague, especially with complex procedures initially. So I feel the transition was, gradual, okay? And then, of course, within a few months, we caught on and learned, of course, to work with what was available on the ground. Because I can assure you there was a very big difference between, what was available, for example, in the UK and what was available on the ground at that point in time. So, of course, a little bit of shock, but learned to work with what was available there. I remember, coming to MTRH, and there was an old dusty microscope, not used. I think it must have been donated. And I started using it, and I felt, this wasn't worth it. I felt the government would do better. And I think at that point we had a very supportive hospital CEO, Okay, Dr. Arvas, and when we asked him, well, I asked him, well, can you consider getting us maybe a better microscope? And he didn't question much. It was put in the procurement plan, and we actually bought a microscope worth 32 million shillings. That was a big investment at that point. So I must appreciate that the administration was very supportive and continues to be very supportive in the journey of realizing actually specialty care, which can be actually very costly. Yeah.
Okay, so it would be interesting to hear from you about how Eldoret especially compares in terms of neurosurgical practice to Nairobi and to the UK in terms of the cases you deal with and the challenges that you have to face on a day-to-day basis.
I must say, okay, not just the UK, you've been, to many centers that we consider world excellence centers, both in the UK, in the US. I've been to a number of centers. And I must say, as a country, we've done pretty well. Because right now, I think we actually do all of the most complex cases locally. If the patient, the only things that we miss is actually what I would consider adjuncts, okay, or what is needed thereafter. There's a number of procedures that I'll do, and I'll say, well, this one needs, for example, a proton beam therapy. This is not available. Not even within Africa and so forth. But generally for neurosurgical procedures, except for things such as functional neurosurgery, things that maybe you've heard about, deep brain stimulation for things like Parkinson's and so forth. This we are yet to get there. But this, I believe, we are not still doing them because we still don't have the subspecialties to do that. But the moment I think we actually get to train people to do that, these other things should actually be introduced. So basically what I'm saying is that of all neurosurgical problems, we can actually be able to handle 95% or more of them locally at this point. Yeah.
That's very interesting. So tell us, Dr. Sydney, about your typical life or your typical day as a surgeon. How does it go like?
So our days will really vary based on what you're doing on that specific day. So there's no day that is actually similar to the other based on what are the demands, the patient demands and so forth. But generally, of course, you'll wake up to doing maybe some ward rounds, get to do the clinics, for example, in MTRH, I'll have to do a ward round on a Monday morning, and do other clinics in the afternoons. Tuesday usually is my operating day in MTRH. It can occupy the whole day. Wednesday, then we have to do another clinic in MTRH again, and then private clinics. And the other clinic in MTRH is usually on Thursday. And then Friday generally is left on my part to doing other activities, if you have, basic research, teaching and so forth. But you see, generally the day is not enough to cover all the work that you need to do. Especially, for us who work for the public and actually work in private. So you'll find us a lot of times in the evenings, running my clinic to late hours, and then I have to do theater. So generally, if you have a long case, might take you until the next morning. But those are some of the unusual days. But generally, finish up by around 10, 11 o'clock, then you'll have done, one or two procedures in private. So that's generally my day. So on rare occasions, then if you have a really long case and you must do it, then it can even take up to 4 a.m. in the next day. Yeah.
Okay. Do you also operate on weekends? Do you do a lot of surgeries on weekends?
Yeah, generally we actually pushed because of the workload in order to actually be up to a par with the rates at which you're seeing patients. Then you have to work on weekends. Yeah, most of the time. Sometimes it's bad enough and you have to do the surgeries even on Sundays. Yeah.
So for many of us, especially the general public, neurosurgery is this complex, scary, precise field of medical science and especially surgery. Tell us about it. What would you say to the people out there about how do you find neurosurgery? Is it as complex as we all think? What's your view?
The truth is, yes, neurosurgery can be complex. But, I want to state it very clearly that, neurosurgery, the entire neurosurgery is, it is a very varied spectrum. From very basic, very simple procedures. Sometimes, I find a patient, very scared of going through a certain procedure. And, I wonder how to, put it across to them that this is really almost nothing. Okay? It's a 30-minute procedure, and it's really not. But provided you're operating on their back, they're still scared. But so the spectrum is actually that wide that they are actually very complex cases. Okay, sometimes that you would even advise, when talking as a group of neurosurgeons, this should not be rushed into. Okay. Should ideally be done by somebody who's subspecialized in that field, for example. So there are some things in neurosurgery that are actually pretty complex. And I think, looking at all these things, I think, that's again what the future holds, that we actually have to get people into the subspecialties, stick there and, become find trained in a certain aspect. So we actually classify them, and actually we can actually classify them even academically and say these are the levels of competence in doing a certain procedure. Even amongst things, for example, let's talk about something straightforward, endoscopic skull-base surgery. That's why this is also a very varied spectrum. There are certain things that can be done by very many neurosurgeons with the basic training. You can do a pituitary, but as you advance to more complex things in the skull base, you actually get levels, and we have actually graded them up to level 3 of competence. So this then shows you how varied the complexities can be in neurosurgery. So looking at even other things such as spine surgery, not every spine surgery is the same. There are these that I've talked about as being, very simple, very straightforward things. And then there are, much more complex, as I would say, complexity of the spine increases as you go up. As you go up, let's say towards the neck. Okay. And, to a certain point that you feel that certain procedures should only be done by certain people trained in, well trained in that aspect. So the spectrum is really wide. And, but of course, what I would tell the population is, one is never really to be worried, because as I rightly said, we can actually do 95% of all neurosurgical, or even more, within the country, and there is always somebody competent enough to do your procedure. So I don't think it should be a worry. And there is always this notion and fallacy that actually traveling to certain countries, you feel that you are actually likely to get a better or more competent professional. There's nothing that can be farther from the truth. Okay, because we've actually seen things come back from certain countries, maybe not, they are quite popular, I don't want to mention which ones, that we've actually had to come and revise here. Okay, so it's not always guaranteed that traveling out there is, and you don't really have an idea who's actually treating you there.
So what would you tell people then? Should we still hold neurosurgery with fear and with for many people we think it's that complex? You don't think it's as complex as we should?
There are two people who've always argued, the rocket scientist and the neurosurgeon. So we can say it's true, it's not rocket science. But of course, I think the population should stop feeling it's really just a subset of the medical field, with people just trained in that subset. I think people should really stop being very scared and actually treating it sometimes as a recipe, going for a neurosurgical procedure. I've had patients tell me, well, my neighbor is totally paralyzed after having spine surgery. I think this attitude should probably really stop, and start actually feeling that we actually have the options and the ability to actually give you the best service. So people should really stop being scared about it. Okay. Likewise, of course, how would I frame it? We would like to see also great attitude from the physicians within this field to try and actually give the best that they can. And if you cannot give the best, always refer to the next person who can give the best.
Okay. Are there things that scare you? Obviously, you are a consummate professional, you're at the peak of your profession, but I would still imagine there might be cases that still make you a bit nervous. Maybe give us a few examples of some of the things that have scared you.
So certainly they will always have that, but as this is something that I always discuss with maybe the people close to me. Always tell my wife, okay, I think things have become better over time. Okay, over time, when I first arrived here, I think some of the most scary moments was dealing with things such as aneurysms, for example. But I think over time, with maybe experience and and time lapse, you get pretty comfortable with some of those things. But not to say there are situations where you see something, let's say massive, giant aneurysms in a patient that has no other option apart from clipping. So these are some of the examples of things, or a patient having a very complex tumor in a very complex locality, location. This sometimes can actually give you some anxiety. But the benefits that I feel that I've accrued over time is of course the experience and the technical know-how to approach some of these things. So that's generally what reduces your anxieties.
Okay. Could you tell us maybe one case that comes to mind that you really feel like shaped, or a memorable case, either back in training or back in medical school, or even recently, that really resonates with you?
I don't think I will forget one situation just after I came back from training. And I always call this, it was baptism by fire. So just after coming back from training, minimal little experience, and I get this aneurysm. And as I told you, invited one of my colleagues, who had been in trade for some time. And I start off with a procedure to clip this aneurysm. And proceed. I'm wondering, well, my colleague has still not arrived. So I asked the anesthetist, please call him. And the guy doesn't actually pick up his call. And I have to go through and finish the procedure. I felt was quite a scary moment because, some complications did occur in the middle of the procedure. The aneurysm ruptured. And that always keeps lingering in my mind. And, I look back and I think I would never want to do this to my trainees and colleagues who come up. And by God's grace, the patient was very okay and managed to clip. And I think that was actually my introduction, what I'm calling baptism by fire, my introduction into the system, and to enable me actually to gain the confidence to keep on going into the future. So that was my very early experience when I just came back.
Okay. You also told us earlier, I think, about that the first time you arrived in the UK, they had to send you to theatre to do an operation with the presumption that you are a senior resident, you'd gone through your surgical training, and they expected that at your level you should be able to do. Tell us about that case. What was it about? What kind of case was it, and how did you navigate that?
So now, to that, in fact, I can't forget two cases. One of them, very simple, straightforward procedure, putting a lumbar ring. For some reason, this was pretty unusual in the University of Nairobi. We never got to do one. So I'd never seen one, and they thought, well, that is too simple. Go ahead and put a lumbar drain on that patient. For this one, I had to, go around and find one of the other residents and go and get help to do it. Next time, this consultant surgeon is doing a spine, he's doing a microdiscectomy in theater. So we position, I'm the assistant surgeon. I'm pretty comfortable. I'm just going to be the assistant surgeon, and no big deal. So immediately he puts in the microscope and he steps away and tells me, now you proceed, I'll be watching. And I have to go ahead and start, using my drill. Even a microscope was pretty new to me. And I just learned a few weeks earlier how to do monocular vision and so. So that was one memorable event. It's a simple procedure, but I didn't have the necessary exposure at that point. So, he watched me for a period of time drilling and, being quite timid about, going to the next step and so forth. And finally, he had to take over. And of course, I watched the rest of the procedure and had more confidence now for the next one.
For the next time. So what do you think is some of the challenges that you face, in the profession at the moment, and what would be some of the proposed solutions you might have for these challenges?
Right now, just like everywhere else, it's about resources. There are many things that we would wish for, some of the most advanced equipment and so forth that we would wish for, but we cannot, be able to afford them. And we have had to learn to actually be able to perform, the majority of the procedures without necessarily having some of these advanced pieces of equipment. I think if I mention it to people in the medical field, things such as navigation systems. If you go to an advanced center, they will not actually operate on a tumor without doing, identifying and mapping exactly where it is and continue using the navigation systems as they proceed. So over here now we rely traditionally on anatomy to be able to actually maneuver your way around all that. So, this is an example of some of the things that, they are on a wish list, but might be things to come in the future. I would say they are not 100% critical for, being able to practice in our country. But you can actually make to do in resource-limited centers. So, those are some of the challenges. And then, of course, in terms of resources, is to be able to, provide patients with the highest level of care at a cost that they can afford. This is a big challenge. I normally tell people the purchasing power of most of our population isn't really up there, and we have to make do with procedures and attempt to really give them quality care with the resources that they can afford.
Okay. Now, obviously, I would imagine that neurosurgery is one of those fields where the outcomes sometimes can be adverse, where patients might die during the procedure because it's complex and because of the very nature of dealing with a delicate area. How do you deal with the challenges of difficult cases or where you have to lose a patient, and how do you handle those emotions?
Generally, at this point in time, we would actually like to split the patient's problems into two major categories. The first category is patients who come in with emergency situations, an event has occurred that you cannot do anything about in terms of prevention. And this is where I consider to have the bulk of the patients who can have adverse or negative outcomes. So for these specific patients, I think it is usually very helpful to be able to discuss with the patients and the relatives about, what is the likely outcome of this event. Because we can generally actually be able to give a prognosis or give a likely outcome based on the scenario of things at the patient arriving. So this one generally makes it easier to be able to, eventually break news that this patient had unfavorable outcome and and died. Okay, so it really reduces the impact, the emotion, and the empathy, and the distress that the doctor and the relatives actually go through by being able to give a clear prognostic indicator for the situation. Now, the other big subset of patients is what we call the elective patients. That is a patient who walks to the hospital with a problem that needs to be corrected for them to go back. Okay? Now, for this subset of patients, we actually should work towards what people around the world called zero mortality on elective surgeries. Elective is a patient who's coming very okay, very stable. And fact is, we should actually be working towards zero mortality. And I think, practice right now, we have quite a low, almost gearing towards, I won't say it's almost at zero, but we are working towards that generally. And, in looking at all this, you have to look at the patient as a wholesome patient, look at them in terms of, what are the comorbidities. By comorbidities, what are the diseases do they have? And this can actually be able to inform you as to whether to proceed with this procedure or not, and what are the risks involved in all this and so forth. But apart from that, is having the technical know-how and having and knowing your limits in terms of doing certain procedures, in order not to give the patient, undue adverse events that they did not expect. So if a tumor is unresectable from the word go, then don't do it. Okay? If it's only partially resectable, discuss that with the patient and know that this is the much that we can achieve. Okay? And if a tumor is complex and, should actually be performed by a certain subspecialist, then let them do that and get the best outcome for the patient. So I think that is, I hope I've answered the question about the two varied scenarios.
But as an individual, how do you deal with that then? Because adverse outcomes happen regardless?
Yeah, they do happen.
And in your field, I believe they must be quite common.
Yeah, they are quite common.
How do you deal with it?
So that is exactly what I was trying to put forward, that, I try to prepare the patients and the relatives for the potential outcome. Okay.
But as a person, how do you deal with it
yourself? Personally,
how do you deal with those emotions? Because some of these patients are patients you worked with, you've seen them, you've talked to family. Sometimes even some of them are your close neighbors or relatives, and there's a lot of hope on you. And then something wrong goes.
Okay, now I get what you are driving at. Now, so this is definitely something that has been difficult for me for a period of time. But over time, I've learned to actually audit myself. Okay, audit myself and audit my work. And there's one statement I always ask myself at the end of a patient's treatment, especially if they have an adverse outcome. Could I have done it better? Is there something that I missed out, that I could have done for these patients, And, and if it is true that there's something that I could have done better, I always have to remind myself in future to do it better. That way, then I reduce the burden of self-blame, So generally, I've learned nowadays, to be able to clear these issues at that early level or at that late level, and be able to comfortably clear myself that, well, I did my best for this patient. The outcome is unfortunate. I discuss it with the family as such.
Okay. So maybe tell us what you think is the future of neurosurgery in the next 10, 20 years. What do you think artificial intelligence, AI, does it pose a threat to the profession? Does it pose a threat to you as a person in terms of your competencies? And especially when you talk about robotics and robotic surgery, do you think these are things that would make you a better surgeon? Do you think that these are things that would rob surgeons of their skills or of their way of earning a living? What do you think the future holds for neurosurgery in that regard?
Okay, first of all, within the country, I think there's still a lot of potential for betterment of the practice of neurosurgery. I look down, ahead maybe 10, 20 years from now, and we'll have as many specialty and subspecialists as we could probably require. So I look to a future where we have actually people trained and subspecializing in all, the fields of neurosurgery. With regard to, the technological advancements, right now, well, as much as, people like Elon Musk have tried to suggest that they might be able to replace surgeons, but I believe, even just looking at the complexities in neurosurgery, this is not something that is feasible in the near future, especially for certain aspects. Okay, because for robotics to work, as we've seen, robotics do work for a number of fields. We've used it in general surgery, we've used it in urology, but I still feel these steps that are probably a limited number of steps. Okay, the learning curve for the robotic systems is simpler for certain. That's why it's been really applied to a limited number of fields. So I don't feel that robotics is an immediate threat to neurosurgery, but certainly AI is going to come in place, especially in certain aspects such as decision making. And I feel they are probably going to better decision making because, of course, it's still been at standardizing decision making amongst clinicians is something that is difficult to achieve. But I believe patient outcomes and patient care is going to be actually bettered by AI, especially in the field of decision making. And I think those are the main contributors of technology that I feel are going to come in play maybe in the next 20 years.
So unlike many other people, you're not really worried that technology and AI and robotics and newer modes of imaging are going to make medicine worse. You feel like it's going to make things better?
Well, in terms of neurosurgery, I feel it's going to better things. Okay, technology is going to better things. We might have, the very early parts of robotics might go into even better in certain surgeries. I want to even consider things like straightforward spine surgery where you just need to fix pedicle screws in a very uniform manner, for example. That might be the first entry of robotics into neurosurgery, for example. Looking at the other aspects, so I feel in that aspect, I think it's going to better patient outcomes. On the other aspect that I just talked about decision making, neurosurgery is very unique. For every patient that you encounter, the approach to their management is actually unique. And you have to, there's a thought process that goes into that, and you have to input a lot of things in finally deciding how or what is the best approach to management of that patient. I think in order to standardize this and avoid, the very varied opinions that are not usually necessarily science-based, I think robotics is, not robotics, but AI is going to be an instrument that's going to really be useful.
To make things better.
Yeah, so I feel generally technology might make things better in neurosurgery.
Okay. Okay. So do you think medicine as a whole is becoming more complicated or less complicated with all this, especially your field?
I wouldn't say so. I feel, like the persons entering the, medical field currently, I sometimes feel they're having an easy way through. You'll ask a registrar a few questions and all they have to do is go to the side and have a Google their answers and so forth. So, I feel medicine is becoming easier and easier. There is no doubt that certain fields in medicine might truly be taken over by AI. But, of course, there are still a lot of challenges in ensuring that, in ensuring quality products by these AI services. But generally, it's true, some fields might be taken over. But maybe not immediately in neurosurgery. I don't foresee that.
Okay. So I think last but not least is to ask you, there'll be some people in the audience who will be watching, wanting to see how a neurosurgeon looks like and what the life of a neurosurgeon looks like, what would be your advice to someone out there who wants to be a neurosurgeon? There might be a young man or a young lady now in high school or in some level of medical training, and they're thinking that they want to be a neurosurgeon. What would be the advice that you would want to give them?
You're welcome anytime. It's no longer as difficult to get into neurosurgery as it has been in the past. It's been considered an elitist club in the past, but not anymore. So, and I believe, going through the system is actually much easier now than it has been in the past. So, no need to be scared. If it's your passion, and you're welcome.
You're welcome.
Yeah.
Okay. Are there any particular skills that you feel that someone needs to have to be an excellent neurosurgeon?
There are many things that you would consider, because again, I always watch my trainees, and I can be able to actually pick out why this one cannot learn this skill as fast as the other one, and so forth. And I feel basic things that you need to have as a neurosurgeon, even though we have traditionally not demanded them, is ability to do fine movements very fast, have very good eye-hand coordination, and have even things such as stereopsis. Okay, because you need to, I think the ophthalmologists have traditionally looked into deciding whether somebody goes into their program based on things like stereopsis, being able to judge depth. And I think it's also a big issue. If you're going to do your work very well, you need to be able to. And unfortunately, this is not found in everybody.
Okay.
Yeah, so it's a natural phenomenon. Okay. So not everybody can have it.
Not everyone can be a neurosurgeon. Okay. And if you could go back and give advice to your young self, anything that you might want to tell yourself back in high school or back in medical school, based on what you know now?
Yeah. Well, that's sometimes a difficult question, especially considering that God graciously allowed me to get to where I wanted to be. So sometimes I look at the small things that I missed out on. We talked about the extracurricular activities back in high school. We talked I didn't talk about it, but I really had a negative attitude to certain subjects. History, for example. It was compulsory in the first, maybe Form 1, Form 2. I thought it was an absolutely useless subject, and I looking back, I wish I had read more history, because this is what comes back to an important aspect of just general knowledge. So right now I take my time sometimes to read more history at this point in time.
Okay.
But I had really negative attitude. I had a lot of negative attitude to French, for example. Yeah.
Okay. Now, outside of medicine, obviously you have a life outside medicine. Could you tell us about briefly your family, your hobbies, your other things you do outside medicine, and what keeps you grounded?
Yeah, okay. My maybe looking at the back. So my family, my parents live away. They live in Kericho, but I visit them once in a while. Okay, I appreciate that. They are alive this time. They are aging, but I thank God that they are around, and and we enjoy a brief moments together every time we visit them. So I am married to one wife. And I have 3 daughters so far.
Okay.
Yeah. So I enjoy, of course, a lot of my time in their company. Anytime I have my free time, go back home. So I really don't take time to go visit a lot of social places, because every free time I have to go and have time with them. So in terms of my hobbies, what I do outside neurosurgery, very limited. But I like to, at some point I almost became an athlete. Maybe med school blocked me from that. But so that's what I do most of my time. It makes my, whenever I have free time, go maybe running at the sports club or jogging around and so forth. So that's what I do as an extracurricular activity, just for fitness and so forth. Many other things is, I would like hobbies such as farming, a little farming here and there. I like taking a lot of trips to interesting places here and there. So those basically make most of my bigger hobbies.
No golf yet?
I don't play. I didn't like golf.
Okay. Now, just as we come to a close, obviously, I think neurosurgeons are some of the most successful doctors and some of the most successful professionals. So maybe tell us, what does success mean to you? What do you define as success? And do you think of yourself as successful?
This you could almost say this almost changes every day, your measure of success. But I think at the end of it, I think the main measure of success, in my opinion, is actually having patients appreciate the service that you gave them. That's the greatest success, in my opinion. A lot of people think things such as money. You cannot have so much, and you cannot also have enough of that. So I think the greatest measure of success is actually having patients appreciate the service that you gave them, and looking back even as yourself, whenever you audit something and see that you did something that everybody knows is pretty challenging. Well, not everybody, but your peers, your colleagues in neurosurgery know this is a very challenging problem, and you've done it successfully, and time and again you've done that, those challenging procedures and so forth, and the patient appreciates the much you've given them. Sometimes patients never really sometimes get to know what you've gone through. A patient with a very simple tumor and one with a very complex tumor having the same results, both of them will never know what was worse or what was most challenging. But generally, anyway, all patients appreciating the service that you gave them, I think, is the greatest measure of success. Yeah.
Okay. And obviously, I would assume that, like in any other field of medicine and like any other profession, sometimes people misunderstand you. What would you like to say to those people, so that people better understand your surgeons? I'm sure some people have misunderstood you sometimes. Maybe people think you charge too much, or maybe people think that you rush to operate for ulterior motives. What are some of the things you'd like to say, sort of to make people understand you better as surgeons?
I think generally, of course, there's been this misunderstanding. I've even had misunderstandings with some of my colleagues, who for some reason suggest that you've told patients that he's been a rush to do this procedure. But anyway, on my own position with the patient, I think I take the time to get them to understand what we're going through. If it's nothing urgent, always give them time to think about it, seek second opinions. Okay? And we formed this habit with some colleagues, especially for things that are in the gray areas such as spine surgery, to always have a second opinion from our colleagues, so that the patient gradually gets to understand that they truly need this procedure. On the aspect of overcharging, I don't think we are able to talk about overcharging in our scenario here, especially in Eldoret. Most of the patients actually cannot pay even the standard fees that are set, for example, in Nairobi. So generally we rarely have a misunderstanding, and we usually also try to understand the patients and where they're coming from and their background and their ability to afford certain procedures. So many a time we don't have misunderstanding with patients because they'll ask for a discount, and I'll gladly give them a discount. Yeah. So usually it's all a mutual understanding. I think if I remember, I think my biggest misunderstanding with a patient in the previous past was a procedure to remove their brain tumor, and they go back later and come back and tell me, well, the tumor is not there, so it is still there. So I am really in doubt about your qualification and and your competence. And I looked at her approach to this, and I thought maybe I did not take her through the whole gist of the matter about what was the aim of the procedure and what, and why we had to leave this part for these reasons. So there was really a misunderstanding in terms of communication.
Okay.
So, these are some of the challenges that we actually can go through sometime. So I think basically I hope I've answered your concerns.
You have. I think I've been promising to give him the last question. So this is the final question for you, Dr. Sydney. If you were not a neurosurgeon, what would you be?
So interestingly, as I said, going through high school, up until my, final year, the Form 4, I was not very confident that I was going to make it to medical school. So I was actually resigned to the fact that if I score an A-, I'd even made my choices. I'm just going to go into engineering and do it because that is what I have qualified for. But really, that wasn't really in my heart. I think that is why I pushed myself the extra mile to really achieve what was in my heart. But fact is that I was actually resigned to actually taking up a career in engineering.
Yeah. What kind of engineer would you be?
I think I had made my choice to do electrical engineering. I remember.
Well, it's been an interesting discussion. We've had a lot of discussions with Dr. Sydney, who is a highly accomplished neurosurgeon. If you have been to Eldoret and you've needed the services of a neurosurgeon, I'm sure you've been referred to Dr. Sydney Rono, especially I think from our clinic. We've been sending quite a number of patients to Sydney, and we're really grateful for him to have made time this afternoon to talk to us and to give us an insight. And we've just scratched the surface of what the life of a neurosurgeon is meant to be. So quite interesting, and we're grateful, Dr. Sydney, for your time, and we really appreciate you coming. Thank you very much.
Okay, thanks a lot for the invite.